questions whenever you want. The floor is yours.
Thank you. Thank you, Nasser. Well, this is like a private presentation for you here. You are just a handful of people, so my pleasure to talk about my favorite topic, as you know, which is the endometrial factor. And as you see in the title, indeed, the endometrial factor matters, whatever we do. And the reason for that is an obvious reason. We know that IVF is not efficient at all, and the main reason for this inefficiency is basically that when we transfer good embryos or even euploid embryos in the endometrial cavity, well, it doesn't lead to pregnancy as much as we wish. This is just the statistic from the Netherlands. But I mean, you can see that, and you know that the step is always from embryo transfer to pregnancy. So when anything is happening in two parts of a function, both partners should be considered. We know that we are an species with low efficiency, and we have high percentage of aneuploidies. We know that, unlike other species. And the implantation rate, as said, is quite low. And the main reason is because there is a decimal control of embryonic implantation. Unlike the mouse, for instance, that they have this diapause and the embryo is just floating around and directing the way and the moment that should implant. So that's why I'm talking about the endometrium, because this is the maternal part that is really important on that. Once the embryo enters in the endometrial cavity, the embryo is going to see the microbiota that is there, and depending on how it is, it will be successful or not. The embryo is going to talk with the mother about how to implant, to adhere, and then invade. So that's why the endometrium matters. So if we just go step by step, today I'm going to refer specifically to endometrial receptivity, which is the physical attachment of the embryo through the endometrial epithelium. And the main clinical problem is that there is a window of opportunity. In our species, only a few hours, a few days. Basically, it's 40 hours with there is availability for the embryo to attach. And this is also a personalized matter. We know this for a long time, that if we transfer embryos outside of this window, they will never implant. So in order to understand how it is this window, we need to understand how the endometrial epithelium works and whether there is a plasma membrane transformation that makes this endometrium receptive. We have been trying to understand this from the anatomical medicine to the molecular medicine. The 𝗺hes criteria, they are updated, of course, and since a long time ago, different groups in the world, they have been trying to understand the transcriptomic signature of the whole menstrual cycle, but also what is the window of implantation? What are the real signature that indicate that at this moment the endometrium will be receptive? So we have done this, and we published this in 2011, and also we double check that at the single cell level. Now, cell by cell, by doing the whole transcriptome, we learned that, and this was published in Nature Medicine 2 years ago, we learned that at the moment of the window of implantation, there are some genes that they are completely turned on and turned off. As you can see there is the window of implantation. You can see the difference of color. So altogether means that there is a window of opportunity that we should assess objectively, and we can do that through a transcriptomic signature. And we know that this window is typically open after 5 days of progesterone, but every patient is different. This is not about generalized medicine, it's about personalized medicine. Therefore, although 70% of patients, the window will be there, and it will take about 30-35 hours. In 30% of patients, the window is displaced, go up to 7 days of progesterone or 4 days of progesterone. And some of them we will have a narrow window. That's why we have been working on the concept of personalized embryo transfer, and we start this for recurrent implantation failure of endometrial origin. And the concept is simple. Instead of transferring the embryo whenever the embryo is ready, to do it when the embryo and the window of implantation of this specific patient is ready. And with that, we started we produced this work a long time ago. This was the first paper that we produced with ERA in recurrent implantation failure. And this is the very last paper that was published this year again for recurrent implantation failure, showing how clinical pregnancy and implantation rate is improved by doing this transferring in a personalized manner. And all the data you can find in this. We published this also in 2022. This is all the papers that they have been published regarding ERA and recurrent implantation failure, and also first appointment. And I just want to summarize with an independent study that was just published from a Chinese group, by which they did this meta-analysis on the clinical efficacy of personalized embryo transfer guided by ERA. And the bottom line of that is that, as you can see here, personalized embryo transfer guided by ERA significantly increased the chances of pregnancy for non-receptive patients with recurrent implantation failure of endometrial 𝗺𝗁𝗁𝗃. This data, they produce this data, they analyze all the publications that they are in nowadays, and for recurrent implantation failure, which is 3 or more prior failed attempts, this was the conclusion, that by doing this personalized embryo transfer, you recover to the level of pregnancy rate for those patients that they have previously failed 3 or more. And for good prognosis patients, there is no statistical difference yet. You see between 39, 5, 40% to 53% with ERA, but it still is not significantly different with all of these 3 papers published. The point of this meta-analysis, and I want to remark this, is that in good prognosis patients with no ERA, this was the pregnancy rate that they found was 40%, with ERA was 53%, no differences. But with recurrent implantation failure, it was 48%, which basically is higher than the percentage that they got in good prognosis with no ERA patients. So the paper is published, so you can see that. And this was our randomized clinical trial in the first appointment published, and with that we learned that by per protocol analysis, we were able to improve these percentual points, 14 and 18 versus frozen and fresh, in terms of implantation rate, pregnancy rate, cumulative pregnancy rate. Live birth was not statistically significant, even if it was an increase of 14 percentual points versus frozen and 10 versus fresh, and it was statistically significant for cumulative live birth rates. We did not see any difference between frozen and fresh, other than personalized. And with that, are we on time? Yep. So the conclusion of that is that modern IRT requires the use of personalized medicine. Generalized medicine to do things because we are in day 5 or day 7, or because we have something. I mean, we should go to personalization, which is where medicine is going. And ERA is a molecular test based on the transcriptomic signature and allow us to individualize the patient and do this personalized embryo transfer in now the most difficult patients. So those patients that everything has failed, and you have seen the references that exist about that. What we have learned is that in 30% of our patients, and of course the most difficult patients, the percentage increases. In 30%, there is a displaced window of implantation that can be corrected by a proper embryonic endometrial synchronization. It's an obvious concept. And finally, PET guided by ERA significantly increases the chance of pregnancy for non-receptive patients of recurrent implantation failure of endometrial origin, and I just show you the independent meta-analysis demonstrating that. And with that, I just want to thank you for being here, and delighted to answer.
Thank you very much, Carlos.